Well, first of all, we appreciate the Medical Society giving us the opportunity to come and participate in this. We're excited about what we're doing, and I'm going to take just a few minutes. I noticed that Steve is the only non-physician up here, but I will tell you going forward, if you're thinking about doing what we've done for the last 15 years, and if you're thinking about getting into this, you have to have a Steve. Grace is probably more important than I am to her organization, but you have to have the business people that understand the dynamics of it. So if you don't take anything else away from here, I'm going to give you the majority of our time. We formed Coastal Carolina HealthCare, merged 4 primary care groups back in 1998, 2 family practice groups and 2 internal medicine groups. And then we've expanded now to 11 clinics, and we have subspecialty representation. The cardiology group that I was a member of, I've been in New Bern since '78 and still have an active full-time cardiology practice. I've lived through everything that you guys have lived through. I've lived through the initial wave in the 90s when Cardinal was here and all the things that happened in Raleigh. We all remember that. And a year ago today, I didn't know what an ACO was and certainly wasn't in favor of it. Steve encouraged me to go up to the advanced learning program at CMS. I begrudgingly did so and came away more excited about the possibilities than anything I've done since I went into practice. We think that there's a way to do this and not only offer patients better care, but also cover. This is the first thing I know of. You got to remember, this is the same organization that bought us DRG, they bought us documentation, and the same organization that now brings us RAC audits. So I was the last person that was an endorser of CMS. But this is the first thing that they have done that aligns their incentive with the physician incentive. If we save them money, then we get to participate in that. So we became excited and we found a way to do it so that we did not have to put our own revenues at risk. We're a relatively small practice compared to some places in the state, particularly like Cornerstone and other places, but we were very excited about it. So we have 11 clinics now. We have a full service. I told the people at CMS, if you can turn our group, you can turn anybody in the state or the country. We're an old-fashioned fee-for-service, advanced imaging, full-scale imaging, ancillary service, primary care practice with subspecialty representation. That's where we make our living. 50% of our revenues come from these 11,500 Medicare people that we're talking about. So when somebody's talking about changing how we get reimbursed for them, they get our attention. We have been excited. Steve, the reason I'm going to let him lead most of this, and I'll be available for question and answers. I'm sure the specialists in the room want to know what a specialist is doing embedded with a primary care group. It has been a wonderful relationship since we formed the organization in 1998, and it works. Somebody handed me one of my nurses yesterday, but I thought it was appropriate, put something on my desk, and she said, it's amazing what a man can accomplish if he doesn't care who gets the credit. And I think that that's what ACOs are going to be about. So with that introduction, I would tell you that we're alive and well in New Bern, and I'm going to let Mr. Knuckles tell you how we've done it and what we've done and what we've accomplished so far. Thank you.
Thank you. I appreciate you allowing me to speak, and Melanie and the Medical Society for the invitation. I will try to be brief. This is one of my favorite topics, though, talking about our ACO. I'm not sure how to make this go forward, though.
Green go.
There we go. David hit on most of this. The specialists that we do have in our group, we have internal medicine, family practice, emergency medicine, cardiology, hematology, oncology, gastroenterology, neurology, and pulmonary critical care. About 2/3 of our practice is in primary care. We do have an imaging center. We do have an urgent care center that has access on Saturdays, Sundays, and most holidays. We do have an integrated electronic health record. When I say integrated, that means we have the labs coming in, we have transcription coming in, we also have imaging services are all integrated with that. All of our providers have met the meaningful use requirements this year, so we've been using our electronic health record in meaningful ways for several years now. We also have some experience with population health management. I'll talk about that a little more, but we think that's very key to not only improving care, but documenting that you're improving it for patient-centered medical home and for, most importantly, to meet the quality metrics of the accountable care organization. Just a brief overview of the Accountable Care Organization. We did enter the Medicare Shared Savings Program, MSSP, on April 1st. That was the first time that we were able to come in. We were one of the first 5. I guess there were 27 in the initial round. 5 of those were advanced payment models. What advanced payment model means is that CMS, when the final regulations came out, they created a new program. And if you had under $50 million in revenue and you were in a rural community, they said that they would give a $250,000 upfront cash payment plus a $36 per beneficiary per month payment. And then they're going to give us $8 per month for each beneficiary during the initial 27 months. Now, this is just a portion of the shared savings. It's an advance, if you will. If we don't, as long as we stay in the program, we would not have to pay CMS back. But if we do achieve savings, then the first dollar savings that we achieved will go back to CMS to repay them for this funding. So when they came out with that model, that obviously got us very excited, and because this really helps fund the initial startup that we needed. We do have approximately 11,000 attributed beneficiaries, and that translates into a budget of about $100 million to take care of them. There are 2 risk tracks within the Medicare Shared Savings Program that we went into the first track, which is non-risk. There is a risk track that you get 60% of the savings as opposed to 50%, but if your costs go up above the national average, you have to pay CMS back for anything that goes above. And you also have to post capital, and there are other requirements to go into that model. On the decision process, we really watched the ACO from the time that it was a component of the Patient Protection and Affordable Care Act. And, you know, we talked about it at our retreats. We also, I think one of the big things we did, though, was we assessed our prospects for success. And there are a number of things that, if you're considering doing this, that I would, that you would want to consider as well. The first one, have other groups succeeded? I don't want to go into that a whole lot, but there was a demonstration project, and a number of the groups did very well. Some groups did okay, but in all, over that 5 or 6 year period, savings were achieved. We also looked to the Medicare Advantage world to see what other groups and partnerships had done there, and there were some models of achieving success, not just with coding optimization, but also with just managing care and providing better care. We looked at the Part A and Part B spending in our area. We compared it to other parts of the state and the national average. Our area was a little below average, but we do know that if spending is higher in any given community, that does increase the prospects for achieving success under this program. We also look to, what percentage of our business would be covered under this. Medicare is a big component of our practice, and it is over 50% of our revenue is derived from this. That goes back to what Dr. Terrell talked about, a focused factory. And so we felt that our practice being, with 2/3 primary care and such a large percentage of Medicare, that would really allow us to change our behaviors and patterns, for all patients, not just this one subsegment. We also, because we had some experience with population health management, we felt that we could meet the quality metrics and that we had the commitment of staff to be able to do this. In any way, the management bandwidth, if you will. We were just finishing our electronic health record implementation, so we weren't going to have to hire tons of new people to be able to do this. We also went through and assessed the risk of the status quo. Well, what happens if we do nothing? I think that's something that every group should look at. One of the things that's not been given much press, but I would encourage all of you to get more information on, is what's called this value-based modifier. We don't have enough time today to go into the details of it, but that is a real risk of the status quo. If you do nothing and you're in a low-cost a high-cost area that has lower quality, Medicare is going to start cutting the fee-for-service reimbursements, if not now, in a few years, just as they're doing to the hospitals right now with the readmission rates. I think that has achieved a lot of, it has received a lot of press over the last month. Dr. Oliver hit on the advanced, the ADLS that we attended at CMS. I think that was key in our decision process. It really showed us CMS's commitment to make this work. They had some really smart people who were there. They didn't have all of the answers quite figured out yet, but we believed and came away with the impression that they were committed to making this program work, and they would take whatever steps to perfect any areas. And to date in the program, they really have worked towards that. Doesn't mean that we agree with everything they do, but at least it's well thought through. And then when the advanced payment model came in, that really sealed the deal for our group. Startup costs. That's something that there has been given a fair amount of press to. CMS came out with in the regulations and said that their estimate was $1.7 million. The American Hospital Association came out and said to start up an ACO would take $5.3 to $12 million. You know, our experience and with our group and having just one tax ID number, we felt we could do this for much less expense. We have spent just in startup cost $200,000 to $250,000, and most of that was just for some add-on software products that we needed. Primary care preparations. So what were some of the things we did to help get ready for this program? The first thing was that we implemented our electronic health record, and that's no small undertaking. For those of you who have been through it, know. We also had to get the discrete data all populated into the system. That's problem lists, labs, medications, other things. And those of you who have been through that, that's not an easy task either. But you need all of that information in order to be able to start reporting on your populations and look at how you are doing with those populations. Also, something that I always thought sounded corny, but it was really important, was you really have to attribute patients to each provider because many patients are tightly aligned, but not all patients are. We've gone through and we've looked at our lists, and some patients are only seen once every other year. Sometimes the specialists think that the primary is responsible for them. The primaries think the specialists are responsible for them, and what happens is you have gaps in care. So it's really important that we align each patient with a doctor, make sure the patient knows that, make sure the doctors know that, so that they have an individual, each doctor has an individual list with the patients they're responsible for, and we can look at those lists and determine the gaps in care, if any exist. Begin reporting on population quality measures. We think that's really important, and for several years now, each month we put our numbers up on the board during board meetings when we talk about financial statements and other things, because we believe that it is that important. We started off with the North Carolina QIO, the North Carolina Center for Medical Excellence, and we've been participating in a number of their collaboratives. Also, regional AHECs are a good way to do that, where we got lots of experience. We've already talked about reporting measures monthly and utilizing a team approach. I can't emphasize that enough. There's not enough hours in the day for doctors to do everything that it takes to get all of these measures in place, especially on the primary care front. The Medicare annual wellness visits, I think, are a huge step towards CMS paying for the resources that it takes to make all of this happen. I know North Carolina only had 8% of seniors received an annual wellness visit last year. We've made that as a real target of our group, and we've been trying to get in as many as possible. And also those annual wellness visits, you can use some of that revenue to help fund the expansion of the team and help fund your primary care transformation. Another piece of advice I would give is don't wait until you have all these things in place to start an ACO. I think you have to start the journey. If you wait to try to get all these things in place, you'll never get them all done the way you want to. And my advice would be to get started as soon as you can. Specialty care preparations. So what do you do? I think the first thing is you have to understand your market and your referral sources, because each market, whether it's in North Carolina or around the state, are going to be very different. I think you have to track those and understand what is going on. Also understand who is forming an ACO. Go to them and talk to them and find out what their interest is. See if you can be part of it. Help them work towards achieving savings and the things that are important to them. I think that's a good way to get more referrals back from them. I think it's also, there was some confusion in the final regs too. They talked about specialists could be in more than one ACO. In practicality, that's very difficult. There are some strategies that are beyond the scope of what we can talk about today, but really if you're a specialist and you sign up with one ACO, it's very likely that that's the only one that you can sign up for. But it is very important. Groups like us would want to work with specialists. We have a number of specialists in our group, and we think it's having them is extremely valuable. There are lots of different payment ways that they can help bring value to the table. So one of the questions I get at these things are, well, this is just a primary care thing, but it's a lot more than that. Cardiology, for instance, is responsible for a huge percentage of the premium dollar, and if you can set up certain pathways and protocols, I think that can provide huge value. In the Medicare Advantage world, they've had specialty carve-outs during capitation, and cardiology and hematology, oncology are usually pretty good candidates for those types of things. Strategies that we have implemented. I think it's important to educate all the providers and staff. One of the big things we did was we just started looking at all of our ED summaries, H&Ps when our patients were admitted. We just created a separate feed that come in on the normal fax line, and we created a database. It took 3 or 4 hours a day to track that, and so we've been tracking that every month. We have our medical director reviews those daily for opportunities, and I think that's one of the reasons when you see the high costs and expenses of some of the startup for other ACOs, they're investing in really high-tech computer systems. Our high-tech computer system is just a fax feed and somebody taking relevant information from that and having somebody who knows what they're looking at look at that and say, oh, this was an opportunity. Somebody came in for, I don't know, pick a condition that we could have easily treated in our urgent care, and the urgent care was open. And then we have somebody call that patient the next day, inquire how they're doing, make sure they know that we have an urgent care, and how that really helps the doctor if all the records are together, and encourage them to use that the next time. And we've had very good response from patients on that. Another thing is that we established an after-hours nurse triage line. We really beefed up that service. We're continuing to look at that, where we can help provide patients next-day appointments and other things to expand access to care. We've also hired care managers. This is, I guess, a play out of, they're in most ACO playbooks. But these are based in our primary care clinics. They're not limited to just primary care patients, but they'll see the subspecialist patients if they're asked to. We have 7 on board so far, and we are slated to hire 4 more. We've already talked about the next day appointments. We also increased marketing for our urgent care because we found a lot of our patients didn't realize that we had that there. And we've also expanded our capabilities in urgent care to have advanced imaging after hours to be able to do certain lab tests that we were having to send to the hospital's emergency department for. So can any of this make a difference? I don't know. Before we start looking at numbers, I just want to caution everybody, this is very early with us. The information that we have here is based on these fax sheets that we have come in every day from the hospital. We've been tracking them. It doesn't include all of our hospitals. There could be seasonal adjustments in this data that we have not corrected for, but this is our initial data that we have. And it does show a greater than 20% drop in emergency room visits since we started the program on April. And so obviously we're very pleased with this. We hope that it stays down, but the official results will know more in probably another 6 months. Hospital admission data. We've also seen about a 20% drop in hospital admissions during this time period. We looked at these figures also compared to our internal numbers that CMS shares with us on a quarterly basis, and they seem realistic, but I know that we're not capturing all the data, and I know the data here is imperfect, but it's the best that we have today. To try to factor out the possibility of seasonal adjustments, we looked at our ACO patients that were visiting our urgent care, and we saw a flat to maybe up a little bit trend here. So perhaps that's a good sign that maybe there's not seasonal adjustments in here if our urgent care was just as busy. But once again, we don't know, and we'll know more later. In each of your slides, there's some additional information on the advanced payment model. There's also some information there that was in the September 12th Journal of JAMA, where they did a really nice summary of the PGP demonstration project, which was the initial 10 groups that Dr. Terrell spoke about earlier. This shows, did they really achieve savings? The one takeaway from this is the dual eligible patients, those with Medicare and Medicaid, I think they had the highest saving rates on that population of patients. And the third item there is the Institute of Medicine demographic cost and utilization, where you can go and see the cost and utilization in your specific community if you are assessing this type of program. Thank you very much. I'm going to turn things over to the team from Key Physicians now.